Good afternoon. Thank you all for being here. We are very fortunate today to have Boston University School of Law professor Aziza Ahmed with us to deliver the Bodenheimer Lecture on Family Law. This endowed lecture was established in 1981 in memory of UC Davis law professor Brigitte Bodenheimer, a renowned scholar, teacher, and law reformer. This lecture brings leading scholars and practitioners to discuss recent developments affecting the family. Today's event is also part of our Racial Justice Speaker Series, which is in its fourth year. The series explores the effects of systemic racism on all areas of law. Now, Professor Ahmed's talk today is entitled Essential Worker, Expendable Family. In it, she'll draw on insights from political economy and feminist legal theory to explore why and how the family has been exceptionalized in the response to the public health crises, actually. Professor Ahmed's scholarship examines the intersection of law, politics, and science in the fields of environmental law, criminal law, health law, and family law. She's a professor in law at the N. Neil Pike Scholar at Boston University School of Law. Before joining the BU faculty, she was a professor of law at UC Irvine Law School, and before that, Northeastern Law School. Professor Ahmed is the author of the forthcoming book, Risk and Resistance, How Feminists Transformed the Law and Science of AIDS. And she's co-editor of the forthcoming handbook, Racism in the Law, with Harvard Law professor Guy Uriel Charles. Professor Ahmed holds a JD from UC Berkeley School of Law, an MS in Population and International Health from Harvard School of Public Health, and a BA from Emory University. Please welcome Professor Aziza Ahmed.
Thank you so much. Thank you for having me here today to deliver this lecture. Thank you to Dean Kevin Johnson, whose work I've admired for a very long time, and to Starla, who I don't see in the room, but she got me here through thick and thin and helped me with all my computer issues this morning. And also thank you to the faculty who have made me feel so welcome. I admire so many people on this faculty, and it's really an honor to be here. And I was walking down the hall earlier and thinking, wow, I'd love to just come and hang out here sometime. So it's an honor to be giving this lecture named after Professor Bodenheimer. When I was preparing my comments today, I started to read some of the pieces. When I was preparing my comments for today, I should say, I was reading some of the pieces prepared in her honor at various occasions, on various occasions of her life, and I was struck by the really important and incredible person and scholar she was, and the feminist network that she belonged to, which really set the stage for many of the ideas that I'm going to talk about today. So for today, my presentation thinks about the exceptionalization of the families. And I'm really thinking about here the families of essential workers and the response to COVID-19, and more broadly to public health pandemics and public health crises. So a lot of what I'm thinking about are the families of essential workers who are at very high risk during the pandemic. But also, I think a lot of the lessons are more generally applicable to how we exceptionalize the family in public health. So I'm going to begin my presentation today by situating us in the world of essential workers and their families during COVID, as well as families during the AIDS crisis, which is another epidemic that I think a lot about, to help set the stage for the ideas that I hope to bring today about the relationship between family and public health governance. And then I'm going to trace two dynamics. The first, the rise of individualism inside of, and the idea of individual responsibility inside of public health governance, and also the role of the public-private divide. And I think by tracing these ideologies, we'll begin to see how they sort of took over our consciousness and the public health response, and really resulted in a failure of a robust response to the COVID pandemic, abandoning families and abandoning families of color especially. A lot of this work I've developed with my co-author, Jason Jackson, and much of it is also rooted in my book project, which Dean Johnson mentioned. So to situate us, I'll just take us back to the early days of the pandemic when state governments issued stay-at-home orders. In this moment, we were all told to stay at home, but one group, of course, was exempted. Many of these essential workers were gig workers, delivering groceries and food, working in restaurants. Many were care workers, keeping nursing homes functioning, caring for the elderly, showing up at hospitals. Most essential workers worked in the food and agricultural industry, and many in the meatpacking industry. But of course, the list of essential workers went on, including wastewater workers and government workers as well. The data collected during COVID reveals a highly racialized and highly gendered essential workforce. The essential healthcare and community-based services workforce, for example, was comprised 76% of by women. 50% of food and agricultural workers are people of color. 5.2 million people in the essential labor workforce are people who are undocumented, and 2/3 of these workers were essential workers on the front lines, people who were defined as workers who could not stay at home. 70% of essential workers, of essential workers, do not have a college degree. This is some data from Ford US and the Economic Policy Institute. The Center for Economic and Policy Research reported that in the meatpacking industry, an industry that received heightened attention during the pandemic, nearly half of the workers who lived with their families lived in a low-income family situation below 200% of the federal poverty line, or a family of 4 living for less than $52,000 a year in 2020. About 12% had an income below the poverty line, and this community of workers disproportionately lacks health insurance, has 1 or more children to care for, and very, very few, less than 2%, have a college degree or more. The Labor Center at UMass Amherst, in their report on Massachusetts essential workers, stressed, unsafe, and insecure, that's the name of the report, also representing how people were feeling, documented that essential workers felt unsafe at work, lacked basic safety equipment and paid time off. Little savings forced people into the workplace, as well as the need to pay for food and housing. And there was, of course, deep housing insecurity at this time as well. The few studies that exist show that parents, the essential workers who were parents, feeling lack of safety at work, really skyrocketed during this period and impacted families' stress levels. Suicidal ideation rose among essential workers, but the children of workers themselves, especially the youngest demographics, 13 and under, reported higher risks of crisis events and mental health events in the home. Hispanic children of workers reported high rates of stress and anxiety, and the children of African American children also had extremely high rates of depression. Latina mothers in homes, in a study conducted here around Sacramento with essential workers and their families, experienced high rates of stress, anxiety, worry, and depression. But I should just say too that there actually isn't that much data on the families of essential workers, because I think the lack of knowledge itself is indicative of how we didn't really think about or study or frame the problems we were having as familial problems. So at high risk of COVID exposure, given the lack of masks and our general state of what Ulrich Beck, a German sociologist, has called expert-generated non-knowing, in the pandemic, what he was writing about the past, but his work was very important during the pandemic for my writing. Wear a mask, don't wear a mask, wear an N95, don't wear an N95, you remember those moments. Essential workers would go home at the end of their workday and inevitably expose their families to COVID. This was particularly true for families and households, for people living in cramped living conditions. Studies started to show this pretty early on. For example, a study published in the Journal of the American Medical Association showed that based on universal testing data of pregnant women in New York City, it was household crowding and low socioeconomic status that were associated with a higher prevalence of COVID. Yet even as information about COVID settled, even as we figured out what was going on, we established, for example, once and for all, that it was an airborne virus. A full year into the pandemic, the CDC offered the following advice to mitigate the risk of contracting COVID, with a resounding theme: be responsible, wear a mask, social distance, avoid travel, wash your hands, clean and disinfect surfaces. In doing so, this kind of sparse advice being pushed by the CDC ignored the lived realities of millions of Americans who live in multi-generational households, experience overcrowding housing or worse, face housing instability and outright homelessness, have no alternative modes of transportation besides public transportation, and have little to no control over their working condition. In other words, the imagined family of the Centers for Disease Control was middle class, lived in a home with multiple rooms, lived in a home with multiple bathrooms, lived in homes where you could be 6 feet away from another person. This family could absorb the cost of one working parent and the closure of schools. The lives of essential workers and their families and households, especially low-wage and gig workers, were completely lost in the proposals being put forward and the public health approach being put forward in the pandemic. Even more obscured were the informal households, the transplanted homes of migrant workers living in tight quarters with workers living with other men and women, people working to remit money home, where there was, of course, also a pandemic afoot. Ignoring the demands of family and household harkened back to another moment for me. I was reminded of my work on the response to the AIDS pandemic and the social movements that transformed it. My book project recovers the story of how women transformed the law and science of AIDS. These are stories from the 1980s and stories from the 1980s that sort of came back to me in this early COVID period. One in particular was an interview that I had conducted with Patricia Knowles, who's one of the few women of color, she's a Guyanese woman, diagnosed with HIV in the 1980s that's still alive today. There are many people who were diagnosed with HIV in the 80s who are alive today, but very, very, very few women of color and Black women who were diagnosed who survived it and made it till today. In recounting to me during one of our many conversations and interviews as I was writing my book project, she talked about her diagnosis of HIV in the context of her husband's death and her infants who soon died after. The challenges faced by women. She described how few public health services were for individual people and did not consider the family. Children, for example, in the 1980s, once public health departments got the message that they should send out support services for people living with HIV, were not allowed to board buses that were traveling around the DC area picking up AIDS patients to take them to doctor's appointments. Where were the children supposed to go? Because of this, women with few childcare options often missed their checkups. Support groups that were designed for men had little to offer women who were caring for sick children while they themselves were unwell. Food programs only provided food for people who were living with HIV, not for their children. She told me about how women, her friends, with AIDS starved so their children could eat in the context of a lack of food and their own sickness. The AIDS response itself had excluded women and ignored the people and ignored the needs of people with families. And of course, in the late 1980s, no one was talking about women in AIDS to begin with. Patricia Knowles began an organization to fill this gap. It's called the Women's Collective. It's in DC. And she took on the burdens that should have been borne by the state to encourage women to go to their doctor's appointments, to encourage women to pool resources, women with HIV. They took turns driving each other's children to school while they could go to their doctor's appointments. They babysat during doctor's appointments. They shared their food stamps so that people could eat. When one woman fell ill, the other took their children in. Without that, oftentimes, in this context of sickness, the children would be taken by Child Protective Services and sent to live with strangers. So, to me, it was a sort of profound moment to see how this was happening again. This is an image from a protest at the Centers for Disease Control by feminists who in the 1980s were saying that the CDC was essentially ignoring the pandemic as it was circulating among women and killing women, but also in the response to the AIDS crisis. So, both COVID and AIDS show clearly that the role and the place of the family has been vastly underappreciated in public health responses. Of course, there are people who have been making some of these critiques in the public health world, but it's a new and burgeoning literature, and that aims to connect public health practice and guidelines to the family specifically. For people writing in this very marginal space, family is a key site of what one set of authors called context, care, continuity, and connections. They define the family as two or more people related by blood, adoption, marriage, or divorce, and whose relationship is characterized by one of the following: social and legal rights or obligations, affective emotional ties, the endurance of intended endurance of or intended endurance of a particular relationship. In the legal world, scholars have also offered definitions of the family, and in their work on family law exceptionalism, Janet Halley and Carrie Riddick write in the American Journal of Comparative Law that we ought to consider a broad framing of the family. They consider the household to be a human association bound through social negotiation and aimed at securing human reproduction, including reproduction from day to day of its members and the production of new human beings. Whether we're thinking of a family or household or kinship network or any of these types of units, they're lost in the context of the public health response. Why? How do we explain this absence on the focus on the family and in the household in pandemics? What are the subterranean logics that essentially make it possible to have an entire public health response to public health crises that neglect the family? So in a series of papers, Jason Jackson and I argue that the exclusion of the family is the outcome of two dynamics. First, a focus on the individual rather than structural responses in public health and in the context of public health crises, especially with regard to pandemics and epidemics. And second, our societal structure of consciousness, and here I'm drawing on the work of Duncan Kennedy and Fran Olson, that shapes policymakers' views of how they should actually be thinking about the law. And the world of the private is the home and the household, and the public is a world of the market and society. And of course, this is something that feminists have theorized for a very long time, and I'll come back to that at the end of the presentation. The latter, the space of market and society, is a legitimate space for intervention of the state, and the former is excluded. Together, these ideological forces help to undermine the ability to respond effectively to the pandemic and continue to shape its response. And I'll end my presentation today with some very, very pragmatic things that I think should have happened, could have happened, should still happen if we were going to be taking family seriously in the pandemic. But first, let me talk a little bit about how we traced the rise of and sort of a core change that happened inside of public health around individualism. And we tell this story in our work through a tour through the rise of specific ideas in law and economics and how those ideas came to sort of enter the world of public health. Now you can begin to historicize the idea of individualism in public health in the United States and in public health in many different points, starting with many different points in time, of course. But if we're thinking about and sort of drawing this arc between AIDS and COVID and the neglect of the family, you could say in both of these situations. One place to start is the 1980s, and that's where I'll begin. And it's also where law and economics scholars began to be very active in participating in public health discourse. So of course we know that in the 1980s, Reagan ushered in new support for dismantling the welfare state, including disability. Recalling Elizabethan poor laws, he vilified people on welfare, and we talked about and began to sort of push forward a discourse of the deserving and undeserving poor. There were unworthy recipients of government support. He racialized the provision of welfare support through a caricature of the welfare queen, a Black woman defrauding the welfare system to live a life of luxury. This myth proved remarkably effective as a rhetorical device to undo the welfare system. It not only tied in with the deeply entrenched racist stereotypes in a moment of post-civil rights, race-based political realignment, but also underscored that what many have now discussed and understood as a neoliberal trope of individual responsibility. It was during the Reagan administration cutbacks to welfare and disability that HIV/AIDS began its deadly journey through the United States, eventually wreaking havoc in Black communities, immigrant communities, and others. As documented by Kathy Cohen in Boundaries of Blackness and in my own book, although often ignored in the early part of the pandemic, intense advocacy efforts like this one on the screen directed the attention of scientists and public health experts, including CDC officials, toward marginalized communities of color. It was because of these activists' call for greater attention to the epidemic and a growing sense that the epidemic was far larger than was being documented by experts that the government was finally beginning to pay attention to the specific needs of minority communities, particularly Black communities, in the context of the AIDS crisis. The CDC shift then was important because, as Kathy Cohen notes in her book, and drawing on the work of Gerald Oppenheimer, who writes about epidemiology, that the CDC is a signaling institution. Though their primary job in the context of pandemics, as we know it, is to surveil data, come up with case definitions, provide weekly reports on what's happening, these reports, what they're surveilling, how they're surveilling, send messages to doctors, they send messages to physicians, and they send messages to hospitals and policymakers about how to prioritize people in care and diagnosis. In the 1980s, as public health agencies began to coalesce around the impending crisis of AIDS, discussions began about what the role of law and governmental intervention should be in the AIDS epidemic. As these questions circulated, many experts, including administrators of public health programs, attempted to explain how the disease was spreading and in turn regulate the epidemic. And this became a whole set of issues that I document in my book. Was it spreading through heterosexual sex, injecting drug use? How do we lean on in? And of course, the story about neoliberal governance and personal responsibility dovetails here with a very heavy emphasis on crime control, but I won't talk about that today here. The law became a way to imagine how AIDS could be prevented and managed. This required asking, what role should the law play in managing the risk of contracting HIV? What role should the public sector play in rolling out testing, for example, or providing people with ways to prevent the spread of HIV? Condoms. Should the government be involved in HIV testing? How about social services to care for families and for people to receive food? These questions put law front and center in the response to the AIDS pandemic. But the increased attention to questions of around law and the public sector rubbed scholars in the emerging field of law and economics the wrong way. In the legal world, this was most clear in the work of Professor Thomas Phillipson and Judge Richard Posner. In a 1993 book, Private Choices in Public Health, The AIDS Epidemic, an Economic Perspective, which received a huge reaction when it was published, Phillipson and Posner outlined a new way of thinking about AIDS and its transmission. The book would go on to become not only launch a huge discussion inside of legal scholarship and economics, but also be hugely transformational inside of public health. Posner and Phillipson challenged the idea that it was necessary to have governmental intervention in the AIDS pandemic. Instead, they called for a market-oriented approach that treated individuals' choices between safe and risky sex as a rational decision. In other words, when you have sex with someone, it's a rational decision, not an irrational one, fueled by love and passion, let's say. They take specific aim at epidemiology, the science of public health, large-scale studies that show how population health works and disease is spread. As a field, they argue, it assumes that individuals almost have to expose themselves or have to work to avoid exposing themselves to risk of infection. According to Phillipson and Posner, epidemiologists do this through these studies, and assuming one uses randomized groups of people to understand population health, it sort of undermines our understanding of the decisions that people are making on the individual level. Rather than study populations, they argue, it is necessary to think about the mechanisms through which information and incentives impact behavioral change and individual choice. By centering the rational individual, Phillipson and Posner argue that one can treat the decisions made in the AIDS pandemic in the same way as decisions made in other markets that economists study. In other words, they developed a line of thinking that helped displace the idea that we ought to study the structures and social determinants of health, like housing, let's say, and narrow to thinking about the individual person. This core idea was taken up by law and economics and transported into public health. One of the core ideas taken out of this line of thinking was around incentives. Treating sex and other decisions that could impact public health as a rational outcome of a cost-benefit analysis, meaning in the AIDS crisis that if you were about to have sex with someone, you quick ran a cost-benefit analysis in your head, meant that behavior change could be incentivized. In other words, with the idea of economic epidemiology, Posner and Phillipson changed the way that one could look at public health, not by simply focusing on the spread of illness, but the incentives to alter the course of a person's individual choice. By focusing on individuals as rational decision makers and treating AIDS like a market, Philipson and Posner argued that the role of the state in addressing AIDS pandemics should be directed away from providing social welfare and health services and toward creating rules that basically produce the incentives to shape behavioral outcomes. And you can hear here the echoes of what will soon become or sort of like the rise of behavioral economics inside of public health and nudging. I'm sure there's millions of studies now on incentives in public health. And I just wanted to point out that, this notion of an equal trade in sex in particular rubs feminists the wrong way. That sexual partners could freely negotiate sex contradicted feminist claims that women are often coerced into sex due to their structural subordination related to economic and gender inequality. For dominance feminists in particular, who believe that sexual domination was the crux of women's oppression and underpinned the logic of violence against women, it was violence. It was this inability to negotiate safe sex that was producing an AIDS epidemic among women, not poor personal choices. In response to this feminist critique, what's really interesting to me about documenting what was happening in this particular moment is that Posner and Philipson are actively engaged with the feminists on these questions. And in Sex and Reason, which is listed here, Posner sort of says, I want to write a book about sex and reason, and who really writes about sex in the law, that I can really engage with. And he concludes it's Catherine McKinnon and Andrea Dworkin, and the leading feminists of the time are the real people to engage with on these questions. But in response to the specific feminist critique, Posner and Philipson, and this is sort of funny actually, argue that if one takes feminists seriously and views society or patriarchy in the case of feminism as shaping the capacity of one person to bargain, the entire logic of rational choice comes down, so that couldn't possibly be right. Rather than coercion, we should see challenges faced by women, and the example he uses are specifically Black women, as a supply and demand issue. And they go on in an article to spin out an example about, it might be in the book actually, but basically about how Black women's constrained choices have to do with a lack of supply of Black men. And we can talk about that later if you like. So the World Bank, among other institutions, took this approach seriously, interrogating its merits through a series of papers and reports. These modes of studies, where populations were divided and studied with regard to incentives, here's early World Bank report in 1994, would take on these studies, which were about dividing and studying people with regard to incentives, was nascent in this time period, but it was going to take on force with the rise of behavioral economics in the 1980s and 90s. The core idea that focused on behavior change was asking how incentives and choice could essentially change people's behavior, and it would be revolutionary, altering the fields of public health and beyond. And in this book, by the way, Confronting AIDS by the World Bank, the book jacket of the book basically is the first few paragraphs of it, or it might even be the book jacket of Posner and Philipson's book, but they've basically wholesale taken the text and put it on the back of their book. They cite to it, but they use that work very, very heavily. And here's an example of the types of studies that I'm talking about. So in this study, for example, a group of scholars is asking, male sex workers in Mexico City have this disproportionate burden that they carry of HIV. How much money could we pay them to stop having unprotected sex? So they basically divide groups of people into 3 groups, and they give one group $50 a month and one group $75 a month. I might be getting the numbers wrong, but basically they're trying to see, well, how much money do we have to pay someone to incentivize them to act differently? So it's not asking, for example, how are the structural conditions of their life forcing them into a situation where they're vulnerable to contracting HIV? They're very explicitly saying, how can we pay them? What do we need to do to incentivize you to stop behaving that way? So it's a really really important shift that happens. I'll just leave it here for now. So the idea that individuals made decisions that control their health and destiny dovetailed with the market-oriented political and economic ideologies of neoliberal governance that through the 1980s and 90s was slashing public services, as I said, and across the board, while promoting progress through individual entrepreneurship, hard work, and personal responsibility. Their ideas inspired studies, motivated global governance institutions to take an incentives-based model to responding to the AIDS crisis. And in truth, public health never recovered from this turn towards individualism in the 1980s, which was only reinforced through the retrenchment of ideologies of personal responsibility and individualism through the 1990s. The effective undermining of public health infrastructure meant that when COVID hit, and you guys probably remember this very clearly, we were all sitting in our houses, but we had no idea what was happening because we had no way or ability to collect surveillance data. Labs were not equipped to process the vast amounts of saliva samples that were coming in. The patchwork of healthcare of Americans led to holes and gaps about information in the pandemic. And you know, the New York Times had a bunch of articles, if you remember, that early part of the pandemic, basically how state health departments were just standing in front of fax machines that were sort of spitting out information, and paper was flying out all over the room. And they're like, yeah, this is basically how we're collecting our COVID data. Why were they still using fax machines to collect data? Well, you know, it has to do with this sort of systematic underfunding of public health over time. So ideologically as well, we saw ongoing attacks in COVID and pushback against the idea that there should be collective action and approach to public health. The message was resoundingly clear. We act as individuals, we protect ourselves. Your health is in your hands, declared the CDC director in one startling moment, an odd response to a viral illness which is moving quickly from person to person from the country's leading premier public health agency. Regular people were forced to become experts if they could, in the language of viral replication and vaccine efficacy. And the best way to stop COVID crisis was to wash our hands and wear masks. Not, for example, fix the water issues in Flint that prevented people from washing their hands. Not providing tests and masks to essential workers who were delivering our groceries and could not afford them themselves. Not finding housing for people who had a COVID infection and needed to isolate. We, families, and communities were on our own. Take care of yourself, said the CDC. The individualism and lack of concern for structural and social determinants of health dovetailed with another frame that has helped shape our public health response to COVID. And this is the exceptionalization of the family and household unit. This individualization, and it helps show how it helps propel forward this exceptionalization. The individualization not only obscured these structural concerns like water, for example, but the family itself is a site of intervention which requires structural supports, things like childcare, testing facilities, etc. Feminist and family law scholars have long written of the public-private divide as playing an important role in structuring a gendered world in which women existed in the private sphere and men in the public sphere. The private sphere is associated with an affective life in the home, family, care, culture, child-rearing, all of which are deeply intertwined with notions of gender. The public sphere was associated with rational decision-making, employment, and the market. Robert Mnookin described this ideological dichotomy of public and private as enabling a delineation of the legitimate bounds of government coercion, this is a quote, and regulation, the private sphere, where the government has a legitimate role to play, away from the where the government has a legitimate role to play, which is the public sphere. In her periodization of the public-private divide, Nancy Fraser, writing about the 1980s, notes that that characteristic of the neoliberal era, where the state has gradually shed its social welfare responsibilities that externalized care work, and this is a quote, onto families and communities while diminishing their capacity to perform it. Fraser argues that the result is, amid rising inequality, a dualized organization of social reproduction, commodified for those who can pay for it, privatized for those who cannot, all glossed over by the modern ideal of the two-earner family. This public-private distinction is so deeply ingrained in our history and in our legal thinking, and I'll, just to harken back to what I said earlier, that legal scholars Duncan Kennedy and Fran Olson have discussed it as a structure of consciousness, something that's in our subconscious. For feminists, the pandemic represented a high point of the operationalization of this public-private divide. We had this she session, women dropped out of the workforce, schools closed. There was an assumption that women were going to pick up all of the loose pieces of the economy and the way society was falling apart. But just to say, and to go back to what was going on in the 80s, even as the public and private divide were being critiqued throughout the 1980s and 90s by feminists and by many critical legal scholars, some economists were leaning into the idea that in the market, the economic man was assumed to be rational, selfish, and disciplined, and in the family, that man was nurturing, caring, affective, and altruistic. The idea of altruism itself carries through in slightly different form in that book of Posner and Phillipson. They describe how some people are altruists and others are egoists. These two groups of people respond differently to legal interventions that aim to foster behavior change. It then follows that understanding this behavioral distinction between people who act altruistically and or from a more egotistical perspective, which they sort of harken as more selfish, is necessary. Understanding how people and how people are, to understanding how to design a successful public health intervention. While Posner and Phillipson's work in this area does not address the family or the household per se, they note in their overall writing on this topic that altruism is enhanced by monogamy, relevant to AIDS, of course. And when they do this, they cite all the way back to Adam Smith's argument in his 18th century book, The Theory of Moral Sentiments, that people are not globally altruistic, but instead selfish towards strangers and altruistic towards relatives and close friends. So we see inside of the sort of law and economics thinking and genealogy that you have this idea that people act altruistically differently in different contexts, and those contexts tend to always be in the monogamous relationship, in the home, with family, with relatives. And we ask in our work, can we draw this line between Posner, back through Becker, and Adam Smith to understand why the home is seen as a place that's outside of public health governance? The COVID-19 response reflected the ideological separation of market and home, and that's what I've tried to show you all today. Reinforcing this idea on the individual. The state emphasis on regulating the public sphere through a focus on the individual reflected an economic logic that sees societal level outcomes as the product of individual aggregate individual level behavior. The implicit assumption of state actors is that people choose to go out into the public and take risk. But when they return home to the private sphere of the home, they're almost in a risk-free zone. You almost got the sense, reading the CDC material, that you could walk in your house and take off your mask, right? You're not gonna get COVID at home. Much like feminist legal scholars have long argued was the case with domestic violence, where police just stopped at the door. Public health regulation refused to enter the supposed private sphere of the home. The public-private, as it structures public health, reinforces the individual and ignores the structural imperatives that forced essential workers, disproportionately lower income people of color, to face ongoing exposure in the public domain without offering any help to how they might mitigate these risks at home. Even as we shifted the burden of COVID to the household. So what would a better response have looked like? Let me offer some really basic, pragmatic examples. And these are examples that I think both decenter the individual and see the household and family within the purview of public health governance. And perhaps the most vivid evidence, actually, is not really what the government did do, but what they didn't do, as we've now established. But the first was, very early on it was established, after much political debate. You'll remember that Trump did not want the acknowledgement of an aerosolized virus to be circulating, because that would mean that we couldn't open up businesses. But once we established that COVID was transmitted through aerosolized and respiratory transmission, air filters became a key intervention recommended by the CDC. And public health guidance about schools especially, HEPA filters featured heavily. The idea that the virus was aerosolized, it wasn't just transmitted through respiratory particles. It became clear that schools would need to be properly ventilated, and there was a lot of discussion, but never about the home. People who could afford air filters went and bought them, and in fact, air filter sales spiked dramatically. But even as air filters became central to the COVID-19 response, and although transmission of COVID often took place in homes, and especially where individuals were essential workers, the home was totally ignored in the public disbursement of resources around air filters. A common sense approach to decreasing COVID transmission in the home would have been to distribute HEPA filters to essential workers, especially to their homes where they were unable to mitigate through social distancing efforts. And of course, and just recently, again, the New York Times describes how despite this awareness we've had now for the past 3 years, we've seen very few structural interventions that have actually resulted in, whether at schools or at home, an actual focus on ventilation. Isolation at home was also key to stopping intra-home transmission of COVID. We all know the logic. You isolate, and then if you're infectious, you don't give COVID to someone else. Many, however, found it difficult to follow the CDC guidelines, quarantining at home, which of course, had this middle-class imagination wrapped into it, which is that you have multiple rooms, you have multiple bathrooms. It suggested that the person with COVID should maybe try to stay in that separate room. These guidelines were premised on the idea that there was additional space in which to isolate. Now, early on, some cities did respond to this, and this would have been the proposal here, that like New York City had the COVID-19 hotel program. It was specifically designed for people who needed to isolate and did not have the space to effectively do so. The city offered free hotel rooms to people up to 10 days, During pandemic surges, these hotel rooms were in short supply. And in fact, when we were doing the research, when we were initially writing up some of this work, there were no rooms available. So even if you wanted to use the room, so there was a supposed push for housing, but there was no rooms available for anyone to use. And now all of the programs have been shuttered. So if you have COVID now and you live in a home and you would like to get access to housing where you could isolate and perhaps not infect a vulnerable member of your household, there is nowhere for you to go unless you're going to pay out of pocket. Self-testing via rapid tests provided another opportunity to make an intervention into the home. Rapid tests got emergency use authorization in 2021, and we all started using these rapid tests more and more frequently over the years. But of course, as you know, it was very difficult to acquire these tests for a long time, and we weren't able to get them in the mail. And now, rapid tests are not being covered at all. So again, if we were thinking about workers and their families, we would need to make these tests available. So I'll just end by saying that, the pandemic continues to reveal racial disparities in health outcomes and health prevention efforts. In May 2023, the Kaiser Family Foundation noted on the 3rd year anniversary of the pandemic that it's largely Black, Hispanic, and American Indian and Alaska Native individuals who have borne the heaviest health impact of the pandemic. Age-adjusted data shows that deaths are higher for Black people, and rates of infection and hospitalization are as well. Black and Hispanic people are half as likely to have received an updated bivalent booster shot. The proposals are modest that we make in our work, and I'm making for you here today. They don't even veer into the big structural issues that I said. Like some people couldn't wash their hands due to lack of clean access to water, or that workers in meatpacking plants simply don't have health insurance and don't have homes, or don't have a status. That lack of plentiful housing leads to crowded homes in which people are necessarily exposed. And of course, some structural, just to be sure, some structural intervention was attempted. The CDC eviction moratorium, of course, was a key example of an attempt to actually bring about some sort of structural effort to stop the transmission. But unsurprisingly, it didn't make it past the political and processes that we have in the United States, which sort of entrench a resistance to redistributional politics. So a few days ago in 2024, the New York Times ran an article with the headline, "COVID has resurged, but scientists see a diminished threat." And in the article, I was struck that a few paragraphs in, the New York Times reported that 1,200 people were still dying every week of COVID. They offered no clues as to how we might feel about this number. And I think, I was reflecting on that, and I think maybe as a society we've decided that this is an acceptable rate of death. But if we haven't, it strikes me that we need to continue to unravel the various barriers that are preventing a true and robust public health response. Thank you.
We have a few minutes for questions, so I'll leave it to Professor Ahmed to take questions.
Yeah, thank you.
So, thank you for that. That was a wonderful topic. I have a couple of comments and maybe a question. It occurs to me when you're talking about altruism versus egoism.
Yeah.
That one of the things that was done during the pandemic was that the altruism was structured into who had to work, right?
Right.
So altruism was about was not just in the family; it was for workers.
Right.
Who had to continue to work.
Right, yeah, that's right. There was a sort of, that's not exactly the way that Posner and Phillipson used it, but you're totally right that there was a lot of discourse around sort of these essential workers who are coming home. And in fact, as I was looking for examples, I went to the website of a food packing company. I'm forgetting the name, but they're a big one. And they have on their website, for example, like, thanks to our brave workers who are coming to work every day, we've set up childcare centers for them. But it was so interesting too, because they're a private corporation, and the childcare infrastructure they've set up relies on the Boys and Girls Club of America, to which they gave a donation so that they would send teenagers over basically to watch the children of the workers. And so it was, they really did mobilize this idea of sort of altruistic choices that were being made on the part of workers. Yeah.
But they also mobilized the idea that meatpacking
Right.
should be essential work, right?
Right,
That
exactly.
would have been a perfect structural change where the
Yeah.
government could have said, all right, we're going to ration meat for whatever,
Right.
maybe
Right.
2 years or whatever.
Yeah. Yeah.
That I think would have changed the way that you think about essential work.
Exactly, yeah, and it would have been a more subtle intervention into sort of like a redistribution. What would it mean to ration meat? What would it mean for those workers? And could we have made some space in there for workers to have basically stayed home when they were sick and taken care of themselves when they were unwell, which they were unable to do, basically. Yeah.
I'll ask a follow-up question.
Yeah.
Thank you for the talk.
Yeah.
So important. And I guess I'll say it. In some ways, I think is a reflection of what I always try to say, which is everything is family law.
Yeah, totally.
Everything should be thought of as family law. But I guess to follow up on Letty's question, and this is of course a big question and one that no one has answered successfully for decades, but I guess I'm curious about your reflections about how to successfully intervene in this persistent attempt to frame these important policy questions as individual decisions. How do we shift that way of thinking to the lens that you want us to use here?
I do wish I had an answer to that question. I do feel particularly demoralized at this in the particular moment we're in about the state of the world. But you know, I think part of the, if I were to take a very pragmatic approach to that question and think about, well, what did feminists in the past do? You know, like the feminists that I'm writing about, the social movements that I'm writing about, what did they do? And in the context of pandemics and public health, I do think there's an opportunity in that if you can sort of generate a legitimate scientific discourse about the condition or the issue, it can demand a response. And so I think that's one of the reasons why it's really important that the NIH, fund, for example, studies on the families of essential workers where they have not quite yet. We can see a transformation happening in long COVID, for example. It's not family per se, though of course there are many family implications to the long COVID issue, but if we have, activists in the long COVID space have been very powerfully and effectively able to essentially demand recognition of long COVID as a condition. And I do think that it's through that sort of the transformations that can occur inside of sort of the scientific discourse that can generate a sort of legal response that starts paying attention as soon as the CDC starts saying, for example, that maybe we need to have some family-specific interventions. But I was thinking about examples I might give today, and I was reminded of the director of the NIH. Collins during the pandemic at one point said on the news, if you live in a community where there's high viral transmission and you go home to your kids, it might be worth wearing a mask at home because you guys might be transmitting. And Rand Paul, Fox News, everyone just came after him. Like, how dare you basically tell us to wear a mask in the house? How dare you tell us that masking had become so political already by that point. And he basically retracted his statement, which was a completely legitimate statement to make, So it's not an answer, but just some thoughts, on how do we get people to pay attention to the family and the home. Yeah.
I think we have time for one more question.
Yes. Oh, hi. Can you comment about the intervention with giving rent relief to people, and now they're saying, oh, you have to pay back that rent, and in Los Angeles they're also removing some of the rent control, so they're anticipating thousands of people to be evicted. So that seems like some kind of structural response, but now they have to pay it back, or what's kind of going on with that? Right. So I mean, I think in the housing space, there's been some of the biggest strides forward in actually thinking about how do we sort of have use housing and as a way to sort of stop the spread of COVID, for example, because it was even in the AIDS crisis that housing became identified as an issue that was very, very important. And some of the housing rights organizations became leaders in the AIDS space because there was such a clear connection between HIV transmission and lack of housing. And I think some of that was mobilized again in the COVID context. But I agree that, basically in the few moments and few examples we have of a strong state response when it comes to housing, when it comes to decreasing rent, when it comes to rent control, we see a huge pushback. And of course, it's coming from landlords, it's coming from realtors associations. We see how the eviction moratorium fell eventually through the sort of political mobilization of business lobbying groups, basically. And I think that's basically a retrenchment, into that same political discourse. Oh, well, maybe I should stop there. I have a little bit more to say, but I feel like we're running out. Yeah.
Well, thank you very much.
Yeah.